engine running.
Absolute genius.
Get this.
Welcome.
This is the show where we bring you
Science.
What that essentially means is
discoveries,
advances,
questions,
Research.
technology. Unbelievable.
Without further ado,
this is The Naked Scientists. Hello, welcome to the Naked Scientists podcast. This is the programme that brings you the biggest breakthroughs and talks to the major movers and shakers in the worlds of science, technology and medicine. I'm Chris Smith, and today, as the world unites behind Antibiotic Awareness Week, we're exploring some of the exciting new scientific breakthroughs that we hope will help us to combat the rising tide of antimicrobial resistance. Antimicrobial resistance, or AMR, as it's more frequently called, causes millions of deaths every year, and it happens because the medicines we've traditionally used to treat infections are no longer working. With that in mind, global health bodies have come together each November in a bid to raise awareness about the issue. This year's campaign has just drawn to a close, but despite these efforts, new data from the UK Health Security Agency suggests that antibiotic-resistant infections in England are continuing to rise steadily, with hundreds and hundreds of new infections every week. And the UK is no exception. This is a global problem that needs urgent global solutions. And that's what we're going to explore this week. We'll hear shortly how scientists are taking novel approaches to combat the rising tide of resistance, including a breakthrough vaccine approach for TB, ways to power up old antibiotics, and a return to century-old technology based on bacteriophages. But first, how does antibiotic resistance happen, and why? Colin Brown is an infectious diseases consultant with the UK Health Security Agency.
Essentially, antibiotics, when used to kill bacteria, almost by nature, challenge those bacteria to find ways to become resistant. A lot of them are derived from things that funguses produce to kill off bacteria. So penicillin, if we go back to the start, was produced by Penicillium, and it was that fungus's activity to try and kill off bacteria that developed the concept of using these products for human use. But they've been exposed to them for millennia, and each time there's a product that tries to kill the bacteria, they are very clever and they find multiple ways to develop resistance. They can chuck the antibiotic out of the cells once they get into them. They can get their membrane to provide defenses so that the antibiotic never gets into the bacteria. They can have enzymes that break down the antibiotic. So there's a myriad of different ways that they can provide resistance. And we're giving many, many more antibiotics across the world. It means that we have to be now very, very careful about the use of antibiotics to ensure that they are appropriately targeted to be given for the very right people at the right time for ideally the shortest duration as possible that will have a clinical effect, so that we try and decrease that ability of the bacteria to develop resistance, because we know that is happening more and more across the globe.
Alexander Fleming, who invented or discovered the effect that is penicillin, he himself documented the emergence of resistance in his own experiments 100 plus years ago. So why has it taken all this time before now we're confronting this and we regard this as a big problem?
I think if we go back historically, resistance was always known and it did develop, but there were ever more antibiotics that were available. There were different classes of antibiotics, so they worked in a completely different way. And those were appearing quite rapidly from early introduction of antibiotics in the late 40s and 50s, right the way through to the relatively modern era. We've seen a decrease in that, and there's many reasons why that's the case. But we no longer operate in the understanding that we will always have a new antibiotic that will be just around the corner. And I think also increasingly we're realizing that some of the newer antibiotics, which by definition quite often target more and more bacteria, so they're more broad spectrum, we call them, but they can also have a wide range of effects on the things and the bacteria that live with us very happily and kind of live alongside us in our daily lives. So I think we're also recognizing the tension and the difficulties of giving lots and lots of antimicrobial prescriptions. And I think an increasing global recognition that in lots of the world, particularly where there is challenges with access to medical diagnostic tests, so they don't really know what bacteria specifically they're able to treat, and therefore a rather blind use of antibiotics, that resistance is really, really becoming a big, big problem. And that if it happens globally, it happens everywhere because people travel, bring bacteria with them on their skin, in their guts, and therefore if something is happening in one part of the world, it will soon happen in many parts of the world.
Usually, if there is a demand for something, then an economist would tell you a market will spring up to serve that demand. So, why is there a huge demand for novel antibiotics and an empty pipeline?
There is a paradox to the financial benefits of developing new antibiotics. If you have a new cancer drug or a new heart drug, and those prove to be very beneficial, you want to give that to as many people as possible to create the best impact. Because of the resistance issue and the fact that a new antibiotic, say a new class of antibiotic, completely different than others before, and then maybe one that's going to be effective against the most resistant infections. So, from our perspective, the most valuable new class of antibiotic, we want to lock that away and put it in a box and only release it where there are no other options because there is likelihood of the more we use that, the more resistance to be developed. So we want to protect that for as long as possible because it is a last resort antibiotic. That creates a real disincentive for manufacturers to invest in that. Now, we have tried to create novel ways in the UK. We have a subscription scheme pioneered by NICE, our National Institute of Clinical Excellence, and the NHS in England, whereby we are giving a bulk purchase cost for novel antibiotics. So even if we only used it once or twice or a handful of times, we will give that manufacturer a promise of a multi-million pound investment year on year for up to 15 years to try and incentivize people to bring novel drugs into the system. But even with that, the UK on its own is a relatively small market. European countries are thinking of other ways to do something similar, as are Canada, Australia, Japan, and the US. But those market incentives haven't yet coalesced into something that is really going to change completely the way that companies currently see the investment potential for future antimicrobials and antibiotics.
And therefore, we anticipate this problem will be with us for a while. So, we've got to think laterally, we've got to think originally about other solutions. So, what might they look like? Is it just down to better use of antibiotics? If the more we use one of these agents, the more we get resistance, is the answer just to try to use less?
There is a degree to which we can use less. We call it stewardship. We steward the use of antibiotics, and we're trying to reduce the use of inappropriate antibiotics. But people are getting older, they're getting more infections, they are living longer with complex diseases. We have more people on immunosuppressive treatment that lowers their immunity to infection. So we will be giving more antibiotics. We know these resistances are going to increase. So though we can try and create better stewardship, we also need different approaches.
And some of those different approaches are what we are going to hear about next. Thanks very much to Colin Brown from the UK Health Security Agency. Now, one place that scientists are searching for novel antibiotic strategies is within the medicine chest that we already have, because sometimes we can find powerful new drugs lurking upstream as intermediate products in the manufacturing process that produces the chemicals we already have. And sometimes that manufacturing process is actually inside a microorganism itself. This was exemplified recently when British and Australian scientists were studying an antibiotic molecule that we've known about for many decades, which is called methylinomycin A, which is made in a series of chemical steps by the soil bacterium Streptomyces. What Warwick University's Lona Alcalaf and her colleagues did was to block one part of the pathway making that molecule in the bacteria and then isolate the chemicals that accumulated upstream. One molecule they collected turned out to be 100 times more powerful at killing certain classes of bacteria, and despite considerable effort, the team were unable to make their test microbes become resistant to it.
If you were to go outside and scoop up some soil, you'd find a whole bunch of bacteria in there, and they would be making all kinds of antibiotics to try and kill each other in the soil. And so what we do in our research lab is we try and find new chemicals that might have antibiotic activity, but we also try and work out how they're made. So how does the bacteria assemble these complex chemicals? And there's one particular compound, which is called methylamycin, which is produced by a bacteria that lives in the soil. And we were essentially trying to work out how that's made.
Presumably the motivation for this is that the world is running short of antibiotic compounds that still work in the face of rising antibiotic resistance.
10 million people per year by 2050 will be dying of bacterial infections that we just don't have any antibiotics to treat. And so we really need new antibiotics, and we need new versions of the antibiotics that we've currently got. And many of the antibiotics to treat these infections have come from bacterial sources. It's something like 80%. And we think the best place to look for the new ones is where you found the old ones.
Tell us about the compound you were looking at then, because that's not new, is it? That's one that we've known about. I think it was documented in the 60s, wasn't it? Methylamycin A, which is your starting molecule. So why were you looking at that one in particular?
Because it could be made in an interesting way. So we're also interested in the enzymes. These are proteins that speed up the reactions that we need to get to the final product. Some of those have interesting chemistry, and we're actually more interested in what that chemistry is and how we get to the natural product, for the purpose of using that to look at other systems in other bacteria.
Oh, right. So almost like the production line that the microbes use to make this stuff. You're interested in unpicking that, not because it will necessarily make something like that molecule, but it might make other exciting molecules that might be useful to you.
Yes, it might make other exciting molecules, or we might be able to pick apart the different steps of that assembly line in order to put it together in a different way, say to make a different compound that might have antibiotic activity. There's lots of reasons to understand the fundamental ways in which these chemicals get made by the bacteria.
And what emerged when you began to do this unpicking of the production line? What surfaced?
Say there's 5 steps along the pathway. If you inactivate the ability of the bacteria to do that last step, essentially you get intermediates blocked up. In the same way, say a car assembly line, if you don't add the paint, you end up with lots of cars that are just silver because they're not painted. So in our case, that blocked up intermediate is another chemical with just a slightly different structure. And what's interesting is the PhD student who was working on this project just took it upon himself to be like, oh, I'll just check if this has any antibiotic activity. It's not something we normally do when we make these intermediates, but he thought he'd just check it. And when he checked it, he realized that it's actually 100 times more active than the final product that the bacteria intends to make.
That begs the question then, well, why didn't the bacteria use it themselves? Why did they chew it up and turn it into a new chemical that's a weaker antibiotic?
It's a very good question. The fundamental answer is we're not sure. It's possible, one, that the bacteria is not using it as an antibiotic in the first place because it is an antibiotic and that's what we assume the bacteria is making it for. It could be using it for regulation or to communicate with other bacteria or a variety of other reasons. It could be about which types of bacteria it's active against. So it's possible that our intermediate just happens to be active against something that we really care about treating, but the bacteria in the soil is not so bothered about killing that because it never encounters it. It could just be a quirk of evolution where this particular strain already had another antibiotic that it was making, and that one was playing a certain role, and so there's no point expending all that energy in making 2 different products, so it developed this one to do something else. It's all a bit of a black box. We don't really know why they're making what they're making in lots of cases.
How did it get tested, though? When it emerged that it might have this interesting antibiotic property, how did you then take that forward and test it? And against what?
So we've tested it against a number of different bacteria. Bacteria typically split into 2 different types. You have gram-positive and gram-negative. Gram-positive is the one that ours works against. It is common that you get antibiotics that are only active against that type because the gram-negatives have a different cell wall that can be quite hard to penetrate. And the second thing is take some of those strains and try to induce resistance. So if you take vancomycin, which is one of the clinically used antibiotics, which there is a lot of resistance to, if you take one of those strains and you can make those strains resistant to vancomycin very easily. And if we try and do that same approach with our new compound, it seems to be much harder to do for our compound to get resistance.
And are the strains of microbe that you're testing it against, are they clinically relevant? Are they the kind of thing that would crop up in the clinic and are a real headache for hospitals and infections?
We use lab versions of those strains just to get an initial indicator of the kind of bioactivity that we can see.
What's your plan then? Is it that you're going to investigate the compound itself to see, well, could we repurpose this into a really potent novel antibiotic? Or are you going to say, well, let's work out how it works and then see if we can build something like it, or both?
I think both, essentially. The first step towards the kind of clinical development side is we haven't yet tested it for human toxicity. So that's obviously a really important aspect of drug development. So probably the first step there is to see how it interacts with human cells and what selectivity we get. And then whether or not that is a problem, we're also really interested in what the target of this new drug is, because we don't really know. We think it's something to do with the cell wall, but we're not really sure. And once we know that target, we can then think about, can we develop similar structures that might be more active or more selective, the various kind of hurdles you have to get over before you can reach clinical trials.
Lona Alcalaf at the University of Warwick on how we can delve into the production chain for existing antimicrobial compounds to discover ways to make new ones.
The Naked Scientists podcast is produced in association with Spitfire, cost-effective voice, internet and IP engineering services for UK businesses. Find out how Spitfire can empower your company at spitfire.co.uk.
Music in the programme is sponsored by Epidemic Sound, perfect music for audio and video productions.
This is the Naked Scientists podcast with me, Chris Smith, and today we're examining the future of antibiotics and new avenues that scientists are exploring to conquer the problem of antimicrobial resistance. In a moment, a new way to prevent something that is a massive antibiotic headache, and that is TB infection. But first, on the subject of TB and the family of bacteria to which it belongs, and that's the mycobacteria, here's a story hot off the press on a new way to turbocharge a technology that's over 100 years old, but which can be incredibly effective when traditional antibiotic treatments fail. We first met the University of Pittsburgh's Graham Hatfull a few years ago when he appeared on The Naked Scientist to explain how he'd helped to treat a cystic fibrosis patient with a hard-to-manage infection using a collection of bacteriophages. These are viruses that attack bacteria that he'd isolated in his lab. But it's not always possible, even with a vast collection of these viruses like the one that Graham's assembled, to find a phage that's up to the task. So he's gone to the next level. He's developed a way to assemble entirely synthetic bacteriophages by engineering sequences of DNA that, when you insert them into bacteria, hijack the bugs and turn them into phage factories. At the moment, it is a proof of concept that it's possible, but it opens the door to developing designer phages that can rapidly be brought to bear against a range of infections.
We've been studying the basic biology of phages that infect these particular kinds of bacteria, that the genus is called the mycobacteria, and they're known to include a number of important human pathogens, including Mycobacterium tuberculosis, Mycobacterium leprae that causes leprosy. But then these other so-called non-tuberculous mycobacteria, which is just a whole class of these pathogens that people get as infections, often as sort of opportunistic infections. They're infections that come on top of some other underlying disease, quite commonly cystic fibrosis patients. And people with cystic fibrosis can get these various types of infections, including with the mycobacteria. And they're very hard to treat. It's a nightmare for the patients. It's a nightmare for the physicians because they try different antibiotic regimens over many, many years, and the antibiotics are quite often toxic and not well tolerated, and they just don't work very well. And so people with these types of infections are really left with few options. And so we had identified, prepared, and provided phages for the first treatment that we're aware of about 6 or 7 years ago now for a patient in London with one of these infections. Since then, we've had a large number of other requests. We get a request of about 100 requests a year from physicians for assistance with their patients, and I think that gives a sense of the severity of these kinds of diseases and these kinds of infections.
It's because you came on The Naked Scientist and talked about it.
Oh,
that's probably where they're all hearing about it from, Graham. But you saved that girl's life, didn't you? She was at Great Ormond Street in London, and she was going to die of that infection. And your combination of phages almost certainly did at the time save her life.
Isabel, who was an incredibly brave teenager, and she had cystic fibrosis and then these infections. She succumbed eventually from the various other difficulties with cystic fibrosis, the transplant, and all the various drugs that she was taking. patients that have lung transplants have the least best prospects out of all of the other types of, major organ transplants. But she still was able to return to close to normal life for several years, where she was able to achieve things that she wanted to do and to tick them off her bucket list. As I said, she was extremely brave, and everything that we and many others have done since would not have emerged had it not been for her and her family's bravery in taking a bold step for these, what are essentially completely experimental therapies.
You've got a vast library of these bacteriophages that you have worked up. And when you were approached to help Isabel, it was because you were able to look at the infection she had and then find appropriate bacteriophages that you happened to have that you thought would work. But now you're seeking to go a step further and actually almost like rationally design a virus so that you don't have to pick and choose. You can say, well, what do you want? And I'll knock you one up. How are you doing that?
We've become very aware of the limitations that there are for using phages for these types of infections more broadly. And often when we are sent strains of the bacteria and we test them against our set of phages, we don't get good hits. And we're left with having to say, well, we're really sorry, but we've looked. Our initial screens really didn't find any phages that might be helpful for that patient. And so we've thought a lot about what we can do about that. And although we are firing on many different fronts to try to tackle that problem, we're also aware of really what is fundamentally the underlying problem is that what we have are the naturally occurring phages that can be found in nature. And of course, nature has done a wonderful job of evolving phages to work very efficiently and effectively, but not always in doing what we would like them to do from a medicine perspective. And so what we would like to be able to do is to be able to sit down at the drawing board and design the kind of phage that you'd like to have that would work broadly and effectively and would do the things better that our naturally occurring phages don't do. And so the question then is, how do you go about doing that? How do you make designer phages? How do you get to make phages and phage types that have never been seen in nature before? And so that's what we've been tackling. And there's been a number of advancements in the technologies which have been very useful to us. Two in particular that I'll just mention. One is the ability to synthesize relatively long pieces of DNA, maybe 2,000 base pairs, and to synthesize those even when traditionally they've been very difficult. One of those difficulties is when the proportion of base pairs that are G's and C's is rather high, and these new technologies that have been developed by our colleagues at ANSA Biotech have overcome that problem. So they can make those DNAs and then make them available to us. Secondly, New England Biolabs have developed the technologies that enable us to rather simply and easily take those pieces that we've made and then put them together into the phage that we're trying to construct. And so collectively, we're able to do that. And we've done that for two completely different phages that we're interested in and have synthesized them, assembled them, and then have been able to get those pieces of DNA back into the bacteria such that they now reprogram the bacteria in order to make the phage particles that we can then propagate and study just as we would anything that we had isolated in the lab. So this is really super because now we can really make any variations of these. We can make any phages that we want to, basically, as long as we design it carefully so that it works. And the power of being able to do that engineering is really, I think, quite enormous. It feels like the sky's the limit.
What a great story. Graham Hatfull at the University of Pittsburgh there. Finally today, we are putting tuberculosis, or TB, as it's more commonly known, under the microscope. TB is probably one of the most important bacterial infections in the world. Estimates are that as many as a third of the global population have been exposed. And it's very hard to treat, and getting harder with the emergence of multiple and more recently extensively drug-resistant strains of the bug. It can take months to clear the infection. Part of the problem is that we have only a single vaccine, that's the live BCG vaccine, which is made from a close relative of TB called Mycobacterium bovis, and it's quite limited in terms of the protection it affords, and it's most useful only in preventing very young children from developing disseminated disease. Well, now we know why that is, and how to improve on it, because Brian Bryson, who's at MIT, has found that when scientists cultured the BCG to weaken it so it became a suitable vaccine, the bacteria lost the ability to make some of the most important chemical markers that the immune system relies on to detect TB infection. And if you put those missing markers into a vaccine, he's found, you get back something potentially much more effective and suitable for protecting anyone at any age, anywhere in the world.
Tuberculosis still kills 4,000 people every day. 1 in 7 people who have lived have died from tuberculosis. And so, really, if I think about making an impact on the course of human history, what would be transformative is a protective vaccine. Right now, we only have one TB vaccine that's over 100 years old. And for me as an engineer, if somebody tells you there's a 100-year-old technology that doesn't work the way that you want it to, you want to say, let's build a better one. And so that's what we've been working on for the last 7 years or so.
What are the shortcomings with that vaccine? That's the BCG you're referring to, the 100-year-old one.
The BCG vaccine is really effective in pediatric or child populations against protecting them from their TB spreading outside of their lungs. But when you look at adolescents and adults, the BCG vaccine doesn't sufficiently protect them against TB disease. And so what we're looking to do is we're looking to make a vaccine that potentially protects against TB disease in adolescents and adults. The best offense is a good defense. And so we are looking to really design a vaccine that when you do get infected, you want to have the immune system totally ready to be able to find where the cells are that have the bacteria and handle them on the spot.
What's the difference then between that and that strategy and how you want to do it and what the BCG can already do?
When we think about designing a vaccine, you want to give the immune system the proteins or the other molecules that it is likely to see when it gets infected. So it's really well positioned to find the infected cells. So the BCG vaccine, unlike other vaccines that we get, is an intact bacterium. It's a form of a cattle tuberculosis known as Mycobacterium bovis that was grown in a way that, through a series of mutation events, lost a set of proteins that actually made it lose some of its virulent properties. So it was, in some sense, tamed so it wouldn't be as dangerous as the original pathogen. But what we've actually been able to identify is that actually many of the proteins that are lost and not present in BCG are the most commonly detected proteins that the immune system sees when it's infected with TB. So it's a simple idea that if you really want to prepare the immune system to see TB, you really have to give it the proteins through a vaccine that it is likely to see when you get infected with TB.
Basically, the elephant in the room is missing with BCG, isn't it? So how do you propose then to put those proteins back and make sure the immune system notices them? What's your strategy instead?
Yeah, so our approach has been to really identify the ways that the infected cell tells you that it's infected. And so the way that the infected cell does this is it presents on the surface a series of barcodes, really kind of representing what's inside. And so we did that, developing some new measurement technologies to understand what happens when cells are infected with TB. And then we said, let's go ahead and design vaccines that really allow us to generate the same barcodes on the surface that would be present during infection.
Right, so having identified the real linchpin molecules that say, I am infected with TB, and that's what a cell would display on its surface, you either give that as a genetic vaccine, like the COVID vaccines, really, or you could, I suppose, give the bits of protein themselves, couldn't they? But when you do this and display these very specific barcode markers for TB infection, what happens? Is this better?
What's different in our approach is two things. One, there are proteins that we can deliver in our new vaccine technology that the existing BCG vaccine just cannot. The second thing, what we showed is that actually there's multiple different types of barcodes that the immune system can display on its surface. And what we've previously shown is that BCG actually does a really bad job of even getting one class of barcodes to the surface. So now with our vaccines, we're actually able to really try to maximize as many flags as possible that really help the immune system see an infected cell. Because you can imagine the more signal you can emit that says, hey, I'm infected, the easier it might be to detect the infected cell. And that's exactly what we've been doing. And that's why I think it can be better.
Does it work clinically, though? If you actually administer these signals to an animal or a person in the long term, do they mount a much better immune response that does actually hit these targets and therefore have the potential to prevent severe TB disease?
So that's a really good question. And the short answer is yes. So you can see that when people actually deliver these proteins that we identified into a mouse and then challenge these mice with TB, the mice have less bacteria than had they not been vaccinated at all. So yeah, I feel pretty optimistic that this class of proteins that we've identified will offer protection.
And how does that compare with the efficacy of the BCG? Or has no one done yet a head-to-head where you do your choice of markers or proteins versus what BCG can do to see if one wins?
Those studies are ongoing. What I can say is that the proteins that we're saying, if you just deliver this protein by itself and compare this to BCG, these single proteins that we've identified as compared to a live bacterium do just as well. So if you look in a mouse model, our single protein vaccines do really great. So this is encouraging. There's certainly a lot more work to do. But right now, what I can say is that I feel totally confident about the class of proteins that we think should be in TB vaccines because they're already giving us signals in humans, in human cells, and in mouse models. So that's pretty encouraging.
A terrific result which will help us to bear down on a disease that kills literally thousands of people every single day. Brian Bryson there, he's at MIT. So, although we began this programme highlighting a major medical nightmare of growing antibiotic resistance, a challenge that former England Chief Medical Officer Sally Davies dubbed as worse than the threat from terrorism, we've heard some inspiring stories of how scientists are now uncovering ingenious and genuinely realisable ways to fight back, and soon. There'll be more inspiration on Friday, when we're going to be unpacking the science behind Santorini's earthquakes and also the discovery of DNA in the near-Earth asteroid Bennu. What's it doing in there? Meanwhile, big thanks to those of you who are listening to us every single week, and especially thank you to those who are helping us with our running costs. If you'd like to join them, please do head over to thenakedscientist.com/donate. We rely very heavily on your contributions, and it is a massive help. You can also leave us a review on your favourite podcasting platform and catch up with what we're up to via Instagram, LinkedIn and X. The Naked Scientists are also grateful to Rolls-Royce. The programme was produced by Rhys James. I'm Chris Smith, and from all of us here at the team, thanks for listening, and until next time, goodbye.